All right, so I'll go ahead and get started. Okay, all right. So I am Monalisa Ghosh. I'm one of the bone marrow transplant cellular therapy physicians here at Michigan Medicine, and I'm going to talk to you all today about a phenomenon and a toxicity really of immune effector cells called immune effector cell associated neurologic syndrome. So this is also commonly known as neurologic toxicity due to cellular therapy. And specifically, I will be talking about CAR T cell therapy. All right, so what is immune effector cell associated neurologic syndrome? This is also known as ICANS. So this is a constellation of neurologic symptoms that occurs after infusion of cellular immunotherapy, which are also known as immune effector cells. And typically the onset of these symptoms is within the first 2 weeks after infusion of cellular therapy, but a few instances can be delayed within 8 weeks post-infusion of the cellular therapy. It's most commonly seen after infusion of chimeric antigen receptor or CAR T cell therapy, which I'll give you some more information about. And the incidence is variable, really depends on the CAR T cell product that is infused. There are multiple products that are commercially available. And the incidence of ICANS occurs in anywhere from 20 to 65% of patients, depending on the CAR T cell product used and depending on the study that you look at. So the only treatment that we have for this toxicity related to CAR T cell therapy is corticosteroids. Anti-cytokine therapies have been tried but have not been effective. So I want to talk to you a bit about the history and evolution of cellular immunotherapies. I'll tell you some basics about CAR T cell therapy, what that is and what we use it for. I'll talk about the two major toxicities, which are cytokine release syndrome and ICANS. And then I'll tell you a little bit more about the pathophysiology of the neurologic toxicity, which is ICANS, and then how we manage it and how we may prevent it in the future. So we've been harnessing the immune system to treat cancer for a long time, really started in the 60s, in the 1960s with allogeneic stem cell transplant, which was really truly the first immunotherapy. Because in allogeneic stem cell transplant, we are transplanting not just the donor's bone marrow or stem cells, but also the donor's immune system into the recipient. The donor's immune system T cells then play a very important role in killing off any of the tumor in the recipient. After allogeneic stem cell transplant, really the next major breakthrough in immunotherapy for cancer was monoclonal antibodies, such as the anti-CD20 antibody rituximab. And after rituximab and other similar monoclonal antibodies, antibody drug conjugates were developed. So these are antibodies that also have a toxin attached to them. For instance, the antibody drug conjugate brentuximab, which is anti-CD30, and then has a toxin attached to it and is used in Hodgkin's lymphoma. We also have seen the development of bispecific antibodies. These are antibodies that have two targets. They target both typically CD3, so they target T cells and bring the T cells into the tumor. And then the other end of the antibody targets a specific antigen on the tumor, therefore helping to facilitate the T cell and tumor interaction. We also have seen the development of tumor vaccines, which help stimulate an immune response of the innate immune system against tumors. The development of checkpoint inhibitors, which are antibodies against either PD-L1 or PD-1, which is the pathway through which tumors often evade the immune system. So this essentially shuts down that pathway so that tumors can no longer evade the immune system, and it stimulates the immune system to then attack the tumors. And then we've come to adoptive cell therapy, which really was developed from allogeneic stem cell transplant with the recognition that T cells have the ability to kill tumor cells. So from adoptive cell therapy, from all that we learned, CAR T cells were developed. So what do we know about CAR T cells and how do we use them? CAR T cells are a novel immunotherapy that's used to treat a variety of cancers, but so far is mostly used to treat hematological malignancies such as leukemia and lymphoma. The CAR T cells are targeted to specific cell surface structures, and the ones that are available commercially right now are targeted to CD19, which is on the surface of B cells. The FDA approved the first ever CAR T cell therapy in August of 2017, and that was the drug Kymriah or tisagenlecleucel, which was approved for childhood acute lymphoblastic leukemia, and then subsequently was also approved for adults with diffuse large B-cell lymphoma. There are currently 3 FDA-approved autologous CAR T-cell products on the market. They all target B cells and are for different hematologic malignancies. Over 1,000 patients have been treated both in the context of clinical trials and with commercially available products as standard of care. We have seen very high response rates. For instance, if you look at childhood acute lymphoblastic leukemia, at 28 days post-infusion of these CAR T cells, we see an overall response rate of 82%. So that means that overall response rate is the combination of people who go into a complete remission with no evidence of disease, and those that have had at least a 50% reduction in their tumor burden, which is a partial response. So that combined together is the overall response rate. And that is pretty impressive compared to the basic standard of care at this point for these patients. That typical response rate would be about 20% with standard of care. Similarly, in non-Hodgkin's B-cell lymphomas, we have seen that at 3 months post-infusion of CAR T cells, we see an overall response rate of anywhere from 50 to 80%, which is compared to about 30% with standard of care regimens. So how do CAR T cells work? CAR stands for chimeric antigen receptor, and these are T cells that are created by transfecting them with lentiviruses or retroviruses that carry the DNA sequence for the chimeric antigen receptor. CARs, the structure, as you can see on the right here, this is the structure of the CAR. There are 3 generations of CARs. The first generation just had this extracellular targeting domain. This is in the green. It had a transmembrane domain and then a CD3 zeta signaling domain. The second generation of CARs, they added on this blue area here, which is the co-stimulatory domain. This helps to enhance both the persistence and the expansion of the CAR T cells. The 3 CAR T cells that are on the market right now are all second generation CARs. The third generation of CAR T cells are in development, and this is where multiple co-stimulatory domains can be added in to again enhance the performance and efficacy of the CAR T cells. CAR T cells become activated after they bind the antigen for which they're specific to on the tumor cells, and then they physically kill the tumor cells via direct cell-to-cell killing. A single CAR T cell can kill multiple tumor cells. We know that CAR T cells can proliferate in vivo. Some of them rapidly expand within the first couple of weeks after infusion into the patient. Each infused T cell and its progeny can kill about 1,000 tumor cells. And we know that persistence of the CAR T cells long-term following infusion correlates with efficacy. CAR T cells typically reach their peak concentration in vivo within 2 weeks. And functional CAR T cells can remain detectable for several years post-infusion. As I mentioned before, the co-stimulatory domain determines the behavior of the cells, whether they either rapidly expand or persist for longer. We typically give the patients lymphodepleting chemotherapy prior to infusion. So this is a combination of good T cell depleting chemotherapies such as fludarabine and cyclophosphamide. This allows for better CAR T cell expansion. It literally creates room for CAR T cells to come in and expand in vivo, and also helps deplete some of the inflammatory cytokines that may lead to more toxicities post CAR T cell infusion. The way that CAR T cells right now are produced, the ones that are commercially available and most of the ones that are in clinical trials right now are autologous products, so they come from the patient. There are allogeneic products that are being looked at. They're still in early phase clinical trials. None are available commercially for us to treat patients with. So this does take time, and that's one of the major failings really of this therapy, is that you often are seeing patients who have rapidly progressive cancers, and you have to wait for several weeks before you can infuse this therapy into them. So first, the cells have to be collected from the patient. So patients undergo apheresis. They undergo a leukapheresis procedure. Usually takes about 4 to 6 hours. We typically don't collect for more than 1 day. And we isolate the T cells from the patient and then send them to the manufacturer, who then cultures the T cells with the lentiviruses or retroviruses. They produce the CAR T cells, multiply them, grow, expand them in culture, do all their quality control. And that process takes about 3 to 5 weeks. Then the cells are sent back to us frozen, and we give the patients lymphodepleting chemotherapy for a couple of days, give them a day or two of rest post chemo, and then we bring them into the hospital for the infusion of these CAR T cells. Right now, we typically just infuse CAR T cells once. It's just a one-time infusion. We don't, none of the studies so far have shown that it's effective for most patients to do a second infusion. It really depends on whether they relapse, and if they initially responded to the CAR T cells, can they get a second infusion? At this point, we typically just do one infusion, and then we monitor the patients inpatient for about 10 to 14 days typically. And the reason we monitored them is because of the severity of some of the toxicities. So there are lots of CAR T cells and lots of cell therapies that are in development. This is just the tip of the iceberg. If you look on clinicaltrials.gov, at this time, there are about 646 active CAR T cell therapy studies, mostly in hematologic malignancies, but also in some solid tumors such as lung, breast, pancreatic, other GI cancers, etc. And there are other cell therapies, lots of other cell therapies that are being developed, including those that use other immune cells like dendritic cells, NK cells, just T cells targeted to different antigens. There are lots of other cell therapies in the works, including over 30,000 studies if you search in clinicaltrials.gov. Multiple targets have been looked at in malignant disease, including the ones listed below, and many, many more. However, as I mentioned, CAR T cells have high efficacy, but potentially high toxicity. And the two that we are most concerned about, especially in the acute period, are cytokine release syndrome and then neurologic toxicity. It's also a very expensive product. CAR T cells, the first one that was approved for childhood ALL, has a price tag of $475,000 for one dose. Yescarta and Tecartus were both approved for different B-cell lymphomas, and they have a price tag of $373,000. So just to go over, again, there are 3 current FDA-approved CAR T-cell therapies on the market. The first one is tisagenlecleucel, or Kymriah. This is a CD19-targeted autologous CAR T-cell. The co-stimulatory domain is 41BB. So that co-stimulatory domain has been associated with long-term persistence of cells. It was first approved in August 2017 for treatment of B-cell ALL in childhood. Typically, childhood ALL is a very treatable disease. Most patients respond very well, about 90% of patients, but 10% of patients have either relapsed or refractory disease that really does not respond well to traditional chemotherapeutic regimens. So it has been a very promising therapy for that population of patients. It was the same product was then approved by the FDA for use in relapsed or refractory large B-cell lymphoma. That's for patients who have relapsed or are refractory to at least 2 lines of therapy. The pivotal clinical trial that led to the ALL approval was Eliana. The pivotal clinical trial for lymphoma was Juliet. We enrolled about, I think, 11 patients total on both of these trials at Michigan Medicine. And just so you know, these are both phase 2 trials, and each of them had anywhere from 100 to 150 patients. So there have been no large phase 3 trials of CAR T-cell therapy. There is one ongoing right now in diffuse large B-cell lymphoma, but for the FDA approval of these drugs, they were approved based on phase 2 trials. The next one that's commercially available is axicabtagene ciloleucel, or Yescarta. This is also a CD19 targeted autologous CAR T-cell product. However, it differs from Kymriah, the drug mentioned above, in that it has a CD28 co-stimulatory domain, which is associated with rapid expansion. So these cells typically, once they're infused in the patient, we see peak expansion within 2 to 3 days. They start to peak. And that possibly is why Yescarta seems to be more toxic than Kymriah. The rates of both cytokine release syndrome and ICANS, or neurologic toxicity, are much higher in Yescarta than in Kymriah. However, the response rates are also higher in diffuse large B-cell lymphoma for this drug. And this approval was based on also a phase 2 trial called Zuma-1. The most recent FDA-approved CAR T-cell therapy is one called brexucabtagene autoleucel, or Tecartus. This is also manufactured by Kite Gilead, which also manufactures Yescarta. It is a CD19 targeted autologous CAR T-cell, also has a CD28 domain. The only way it is different from the drug I just mentioned, Yescarta, is that the manufacturing process is slightly different. What they do is they try to selectively eliminate any cells that express CD19 that happen to be in the product, so any B cells or any rogue malignant cells, so that they don't bind some of the CAR T cells, which then cannot bind with cells once they are infused into the patient. And this is FDA approved for the treatment of relapsed or refractory mantle cell lymphoma, so another B cell lymphoma. The pivotal clinical trial for this one was Zuma-2. There are multiple CAR T cells that are pending FDA approval and will be commercially available in the next year or two. Lysocell is another diffuse large B cell lymphoma product from BMS that is going to be approved later in November, most likely. Ide-cel is a drug that targets B cell maturation antigen, which is present on plasma cells and is used for treating multiple myeloma. That will possibly be approved next year. So far, that has shown fairly low levels of neurologic toxicity and cytokine release syndrome, but the multiple myeloma population of patients is a large, very varied and much older population. So we don't really know, once this gets into the quote unquote real world, what type of toxicities we're going to see. And then there will probably be new indications for existing FDA approved CAR T cells, the ones I mentioned above, for instance, chronic lymphocytic leukemia, follicular lymphoma, etc. I just wanted to mention that since these were really phase 2 trials that most of these FDA approvals were based on, we are following these patients long-term just to have long-term follow-up of toxicities. For instance, long-term, what kind of long-term neurologic issues do patients have, or do they develop secondary cancers? What are the long-term immune effects? So we register all patients into a registry study with CIBMTR, which is the organization that we already submit all of our transplant data to, and this is a good way for us to do some long-term follow-up on patients and get real-world data. So what are the major toxicities of CAR T cells? I alluded to this earlier. The first is cytokine release syndrome. So this is the most common adverse event we see post-CAR T cell infusion. It occurs in anywhere from 60 to 90% of patients. The median time to onset is about 2 to 3 days, anywhere from 1 to 22 days. I've even seen it rarely at 28 days post-infusion, but most commonly it's going to occur within the first week after infusion. The median duration is about 7 to 8 days. And what cytokine release syndrome is, it's the activation of the immune system by the CAR T cells. So the CAR T cells themselves do not release a lot of inflammatory cytokines, but they do recruit other immune cells once they are infused into the body, and once they start binding with the target cells. They recruit other myeloid-derived cells, they recruit monocytes, macrophages, dendritic cells, etc., which all then secrete inflammatory cytokines such as interferon gamma, IL-6, IL-10, and GM-CSF, which are the cytokines that have been found to be the biggest drivers of the symptoms of cytokine release syndrome. This is a clinical diagnosis. The presentation is very similar to sepsis, of course, because sepsis is a cytokine storm as well. There have been multiple clinical grading systems that have been developed, but we now have one consensus grading system that we use. The degree of severity is most dependent on tumor burden. So patients that have very large tumors going into therapy, those that have significant involvement of their bone marrow, 80, 90% involvement of blastic cells in their bone marrow, those that have a lot of disease coming in, typically will have more severe cytokine release syndrome, higher grade. We know that development of cytokine release syndrome correlates with response. However, the severity of cytokine release syndrome does not correlate with a better response. In fact, the patients that develop higher grade 3 or 4 cytokine release syndrome actually tend to do worse overall in terms of survival. So as you can see in the image on the right, cytokine release syndrome, much like sepsis, can cause a lot of different symptoms and cause a lot of end organ damage if it becomes severe. So we can see patients develop anything from hypoxia and pulmonary edema with respiratory failure to GI symptoms, to renal failure, liver failure. We most commonly, however, just see a fever in most patients. Most patients develop lower grade cytokine release syndrome. We do often see transient arrhythmias and sometimes transient heart failure as well. Occasionally do see coagulopathies, and cytopenias are pretty common. The neurologic symptoms are listed up there. Cytokine release syndrome possibly precipitates neurologic toxicity. However, we have decided to classify and recognize the neurologic toxicity as a separate phenomenon. Cytokine release syndrome treatment is mostly supportive care, but the mainstay of treatment as you get into higher grades of cytokine release syndrome, meaning that more organ systems are involved, the symptoms are more severe, we do use an anti-IL-6 receptor antibody, tocilizumab. So tocilizumab is used usually for grade 3 or higher cytokine release syndrome. And then if tocilizumab doesn't work, we use corticosteroids to calm down the inflammation. The use of tocilizumab has not been correlated with tumor response. So patients that get tocilizumab still, their CAR T cells are still effective. However, we have seen that corticosteroids do tend to blunt the response of the tumors to the CAR T cells, tends to affect the efficacy of the CAR T cells because steroids do kill or impair T cells. And so those patients tend to not respond as well. This is the consensus cytokine release syndrome grading system that was developed by the American Society of Transplantation and Cellular Therapy, ASTCT. The 3 parameters that we look at are fever, hypotension, and hypoxia. If patients develop other organ damage, that is used in part of our treatment algorithm, but we don't technically grade that in the CRS consensus grading. So grade 1 is just a fever. Grade 2 could be fever with or without hypotension that can be treated just with IV fluids and doesn't require pressors, or with or without hypoxia that requires just a small amount of supplemental oxygen. Grade 3, of course, is more severe. Typically, patients will have fever plus hypotension that may require a pressor, plus increased oxygen requirements. Grade 4 would be fever, requiring multiple vasopressors, requiring positive pressure, including mechanical ventilation. So those patients often have multi-organ failure and are in the ICU. So what is ICANS? This is the other toxicity in addition to cytokine release syndrome that we are most concerned about in these patients. So this occurs in approximately 67% of patients if you look at all patients treated with all CAR T cell therapies. So about 67% of patients with leukemia and 62% of patients with lymphoma. Typically occurs within the first 8 weeks after infusion, but the majority, I'd say in my experience, 99% of the events will occur in the first week or 2 post-infusion. Most events are transient, median duration is 4 days. Clinically, patients often present with progressive neurologic symptoms. So they will sometimes present with mild confusion, expressive aphasia, possibly tremor, dysgraphia, lethargy. They can progress to more serious symptoms, global aphasia, seizures, stupor, coma. Typically does resolve within 1 week. And from my experience with the patients I've seen who have had the severe grade 3 or 4 ICANS, they typically don't seem to remember anything that happens during this time. And as far as we know, there doesn't seem to be any long-term neurologic side effects. But again, CAR T cell therapy is still fairly new. We don't have longer than 3 to 4 year follow-up for most of these patients. So there are lots of ongoing studies looking at the long-term neuropsychologic effects in patients who had neurologic toxicity. It can rarely lead to fatal cerebral edema or intracerebral hemorrhage. So what is the incidence in all of the clinical trials I've mentioned so far for one of the CAR T cell products in ALL and leukemia? It was about 40% in that trial. 13% of patients had grade 3. There was no grade 4. In the DLBCL, the lymphoma trial, 20% of patients developed ICANS, 11% had grade 3 or 4. For the CAR T cell Yescarta, this is the one that tends to have higher toxicities. 63% of patients developed ICANS, with 28% developing grade 3 or 4. And then for the newest CAR T cell on the block, Tecartus, in that trial, it was also 63% neurotoxicity, with 15% developing grade 3 or 4. The new product that's probably going to be approved later this year had somewhere in between, with ICANS rate of 30%, with 10% grade 3 or 4. I just wanted to mention the caveat that at the time that that all of these trials were done, especially the early trials, we didn't have a consensus grading criteria for ICANS, so different grading systems were used. MD Anderson developed a separate one, Seattle had one, UPenn had a different one. So everybody used different grading scales, and it's sometimes some of these scales downgraded some of the symptoms and some of them upgraded. So you can't really truly compare across these trials because different scales were used. So what do we know about ICANS? How do immune effector cells cause ICANS? We think that this is a cytokine-mediated process, so it's sometimes associated with cytokine release syndrome, but sometimes it isn't, or at least sometimes we see it without the presence of a clinical diagnosis of cytokine release syndrome. And we think that it's due to cytokine-mediated endothelial activation, which then causes blood-brain barrier disruption, capillary leak, and coagulopathies. This allows, when the blood-brain barrier is disrupted, this allows high concentrations of systemic cytokines as well as the CAR T cells themselves to traffic into the CNS. We have seen that in some of the patients on some of the early trials, there was correlation between high serum IL-6 and MCP-1 levels within the first 36 hours after CAR T infusion and development of severe neurotoxicity. Also, patients that had evidence of endothelial activation before they got CAR T cell infusion were at increased risk of neurotoxicity. We also saw that patients that have just in general a higher level of inflammatory state before CAR T infusion, for instance, their LDH, their CRP, their SED rate, their ferritin, everything is much higher. Those patients tended to develop more serious side effects, including higher grades of ICANS. To the right, there are some images that are from the autopsy of 2 patients with fatal neurotoxicity. These are patients that developed intracerebral hemorrhage as well as cerebral edema. So you can see some loss of cerebral vascular integrity and multifocal hemorrhage. This is another cartoon that sort of combines the mechanism of CRS and ICANS and gives you an idea of how this works. The first step is that CAR T cells, they come into contact with the target malignant cells, and the CAR T cells themselves secrete some cytokines such as interferon gamma and TNF alpha. And this then signals myeloid-derived cells, monocytes, macrophages, etc., as well, to produce IL-1 and IL-6. Then IL-1 and IL-6 tend to drive the cytokine release syndrome. IL-1 and IL-6 then activate the endothelial cells to express various factors that then contribute to ICANS by allowing disruption of the blood-brain barrier and passage of these cytokines as well as the CAR T cells into the CNS. Also, one thing that's not mentioned in this graphic that has been seen in some of the primate models is that there is significant T cell trafficking, which is helped along by various integrins. So VLA4, some of these T cell trafficking structures that can help the T cells actually bind and roll into and beyond the blood-brain barrier. So this is just another, basically similar to the previous cartoon, just shows how inflammation-mediated ICANS occurs due to breakdown of the blood-brain barrier and, sorry, breakdown of the blood-brain barrier and allowing passage of these inflammatory cytokines. So some of the predictive markers of ICANS, there was a recent study that looked at about 100 patients who were treated for diffuse large B-cell lymphoma using one of the 2 CAR T-cell products that are on the market. And they developed a predictive algorithm to try to figure out who is going to get ICANS and who is going to get severe ICANS. What they found, and this is a small number of patients, but from this small number of patients, the two correlative variables were early onset of fever. So those that developed CRS early, typically, elevated serum IL-6 and MCP-1 serum concentrations within 36 hours of CAR T cell infusion. Characteristics of the patients that were predictive of development of ICANS were those that were younger, those that had B cell acute lymphoblastic leukemia, those that had a high amount of disease burden in their bone marrow, those that got a higher dose of CAR T cells, because not every patient gets the same dose of CAR T cells. It's supposed to be pretty similar, but it's weight based. And so some people get a much higher dose than others. And also the viability of the cells vary. So some CAR T cell products will have 80% viable cells and some will have 90% viable cells. So the dose can vary. And also those that had some sort of pre-existing neurologic comorbidity. Interestingly enough, this was not seizure disorders. Patients that had pre-existing seizure disorders were not at any higher risk, but patients that did have previous neurologic involvement of their malignancy, those that had leptomeningeal disease previously, or those who have had other CNS infections were at higher risk of developing ICANS. Some of the predictors of severe ICANS were elevated IL-2 and IL-5 levels at 3 days post CAR T cell infusion, which may just indicate increased immune signaling. From that same paper, what they found is that there was a marked accumulation of CAR T cells and even endogenous T cells in the CSF. And however, based on the most recent clinical trial data, we do see that CAR T cell infiltration in the CNS has not really truly been established as a correlative with, to correlate with ICANS. So just because you have more CAR T cells infiltrating into the CNS doesn't necessarily mean that you're going to have more severe ICANS. What this graph shows here is that typically patients had either low grade or moderate or severe ICANS. It really did follow the same clinical pattern. So most of them developed symptoms that peaked somewhere between day 6 to day 9, and that was across grades. If you look in panel B, some of the clinical correlatives were, as I mentioned before, measures of inflammation. So ferritin levels, C-reactive protein levels, those correlated with higher than, so grade 3 or grade 4 ICANS. If you look at absolute monocyte count or absolute lymphocyte count, it seemed like patients that had higher absolute monocyte or lymphocyte counts actually tended to develop lower grade ICANS. Why that is not entirely clear. Is there an association between high grade ICANS and survival? So most of these patients that were looked at in this study, in fact, none of them died from ICANS itself. They did not die from the neurologic toxicity. However, those that developed higher grade neurologic toxicity tended to have a worse overall survival. And we're seeing this across all CAR T cell studies, that those that have higher grade of neurologic toxicity or ICANS and higher grade cytokine release syndrome tend to have lower overall survival. And what we are theorizing is that these patients probably just have more inflammation in general. And maybe it has something to do with how beat up their immune systems are before they come to therapy. But most of these patients just in general don't do well. Some of them die from relapse disease. Some of them die from other reasons. The other issue with patients that have high grade ICANS is they're usually treated with high doses of steroids for several days in a row and get very high effective total overall corticosteroid doses, which does increase their risk of infection and other steroid related complications. So how do we manage ICANS, and then how can we prevent it? For monitoring and evaluation, what we have done is we typically monitor patients inpatient for 10 to 14 days. This may change because different CAR T cell products, as I showed you, have different rates of neurologic toxicity and cytokine release syndrome. So some patients can probably be monitored outpatient closely and don't need to be inpatient for 10 to 14 days. But right now, that's the model that we use. We typically try to rule out other causes of neurologic toxicity, including metabolic causes or medications. We usually will obtain CNS imaging. We sometimes don't for grade 1 neuro ICANS, but then for grade 2, we definitely obtain either a CT or an MRI. LPs can be done if clinically indicated to rule out any infectious process. Patients that have a history of CNS involvement of their malignancy, or they have tumors that are in the head and neck area, or if they have very high white counts or some other reason that we think they're at high risk for CNS involvement of malignancy, are typically started on Keppra for prophylaxis. We have other centers have started putting everybody on Keppra for prophylaxis. We have started doing that as well, but that's something we haven't looked at to see if it really, we don't have enough numbers to know if that has made any difference. We haven't had any patients that have developed seizures in a couple of years. We also perform a daily ICE score. I'll show you in a minute what the ICE score is. It really is just a mini mental status exam, but it seems to be a very good indicator of developing ICANS. So the ICE score, it's a scoring system used to evaluate cognitive function. It was previously called the Cartox-10 score, which was developed at MD Anderson. It should be recorded daily for the first 14 to 21 days after CAR T-cell infusion. We usually reassess it at every outpatient follow-up appointment up till about 8 weeks after CAR T-cell infusion. And it basically has orientation questions, name 3 objects, follow a simple command, write a standard sentence, and then count backwards from 110s. The Cartox-10 score was pretty much the same thing, except it asked who the president was, and that was removed for obvious reasons. And then the simple command was added in to the ICE score. So that's how it's different from the previous score we used to use. The consensus ICANS grading system was developed by ASTCT as well, and it looks at 5 components. It looks at the ICE score, depressed level of consciousness, whether the patients have seizures, motor findings, or elevated intracranial pressure. And I think I just saw a question from someone about EEG. So no, we haven't been getting an EEG on these patients before putting them on the prophylaxis, and we don't really have much guidance on that, so I'm welcome anybody's thoughts and contributions on what they think about using seizure prophylaxis in these patients. So we don't really know if it's helping. We don't necessarily know. It's sort of theoretic, and we're fearful that patients who have had CNS malignancy involvement in the past, that they may develop seizures, but we just don't have enough data to really make a decision based on data. So I definitely welcome anybody's opinions on that. But according to this ICANS grading system, so grade 1 would be patients that have a slight decrease in their ICE score, 7 to 9. Grade 2 would be those that have a more significant decrease in their ICE score, but still are able to awaken to voice. Grade 3 would be, patients become more obtunded. They could develop focal seizures. They could have some focal or local edema on scans of their brain. And then grade 4 is typically patients are unarousable, have an ICE score of 0, or they have life-threatening seizures or more significant symptoms. Okay. So how do we manage ICANS? For grade 1 ICANS, which is usually just some mild confusion, maybe some mild expressive aphasia, those are typically the symptoms we see. We monitor these patients, put them on aspiration precautions, telemetry, continuous pulse ox. Usually all patients are on telemetry anyway. They get Q2-hour neuro checks. We would do some sort of brain imaging, lumbar puncture if we think that an infectious cause or maybe early disease relapse is suspected. Detailed, thorough neuro exam. And then we typically will do the ICE score twice daily because these patients can evolve in their symptoms very quickly. And then for treatment, we usually do supportive care with IV hydration. We may start these patients on some anti-epileptic prophylaxis like Keppra. And if they have concurrent cytokine release syndrome, we would treat them according to the algorithm we have. So having CRS typically dictates what the patients are going to get for treatment. So if they have high-grade CRS, we will go ahead and start them on steroids. We found that tocilizumab has not been effective in ICANS. It doesn't seem to be able to cross into the brain and to develop high enough concentration in the brain. So we have not used tocilizumab to treat ICANS. For for ICANS grade 2, it's typically the same thing. We do brain imaging, lumbar puncture, etc. We often will get a neurology consult. Usually these patients, we would start on dexamethasone 10 milligrams Q6 hours. And we continue that and see if they have any improvement within 24 to 48 hours. If they get worse after 24 to 48 hours, we sometimes would give a very high dose of methylprednisolone, typically 1,000 milligrams per day. And I didn't mention in here, but we do EEG on some of these patients once they hit grade 2 or grade 3. That's a good question. I see somebody asked about whether tocilizumab can have a more prophylactic role. So tocilizumab is interesting, and this is something that I'm looking at in a study. Tocilizumab binds the IL-6 receptor. So what it does is it actually increases the effective circulation of IL-6 systemically, because you are not allowing IL-6 to bind to the receptors. You're occupying all the receptors. So you're preventing end organ effects of IL-6, but you're also increasing the concentration, which then typically we've seen can lead to an increase, at least in primate models, can lead to an increased concentration of IL-6 in the CSF. And because of that, we do theorize that that may be causing more inflammation. By giving tocilizumab, you could potentially be increasing IL-6 levels and causing more neurologic inflammation. But that is being looked at in a study. And also in grade 4 ICANS, if you don't see any improvement with the high doses of steroids, you can use anti-T cell drugs to kill off the CAR T cells, such as Cytoxan. These are some examples of the neuroimaging that is correlated with ICANS. These are in some of the patients in some of the early clinical trials where a few patients did die of cerebral edema. So in panels A and B, you can see some of the edema in the deep structures. In C, you see global edema. You see diffuse leptomeningeal enhancement in picture D there. And then in a patient with grade 3 neurotoxicity, this is in E through I, you can see white matter flare hyperintensities, some edema as well, and some, the patient actually ended up progressing with irreversible cortical laminar necrosis about 10 days later. So this was very early. This was maybe 5 years ago, these patients on one of the early clinical trials. This is before we even really knew that neurotoxicity was due to CAR T cells. It wasn't really recognized as a phenomenon post-CAR T cell infusion, so we didn't know how to treat it. These patients would have gotten steroids much earlier. In this case, they didn't even get steroids until they developed cerebral edema. So what are some of the potential strategies to mitigate ICANS? There is no clinical consensus on how long we should continue steroids and how quickly to taper in these patients. There was one study that was done by Kite on, I think it was called Zuma 5 or something like that. But one study where they did intervene earlier with steroids. They treated any patient that developed grade 1 cytokine release syndrome or grade 1 neurologic toxicity received steroids. And so they did lower doses of dexamethasone, and they had a shorter course of dexamethasone. It did seem to prevent development of ICANS, possibly if you compare it to other historical data and the other cohorts of the study, but it's still unclear what the optimal timing is for steroids. There is concern, and there has always been concern, that the steroids will kill off CAR T cells and therefore decrease efficacy. But it seems that in some of the studies that have looked at short courses of steroids with quick tapers has not really shown to significantly affect the CAR T cell viability and efficacy. There are multiple ongoing trials with prophylactic drugs and then multiple ongoing interventional trials as well. So one of the strategies is looking at GM-CSF. As I mentioned before, GM-CSF is a major player in cytokine release syndrome and possibly in ICANS. It contributes to these pro-inflammatory myeloid cells, which then secrete even more inflammatory cytokines. There are a couple of studies looking at anti-GM-CSF antibodies that are administered along with the CAR T cell infusion. And it seems that it has decreased T cell infiltration into the central nervous system and reduced inflammation in a xenograft model. And there is a phase 1 clinical trial that is ongoing. IL-1 is also very important. It's secreted by activated myeloid-derived cells as well, has been associated with ICANS. So in addition to preventing CRS, the anakinra, which is the IL-1 antagonist, is being looked at to prevent ICANS. And it has been shown to significantly improve ICANS symptoms in mouse models. There is one study that's ongoing looking at this in patients, and I have used it off-label in a couple of patients to treat them. One patient did not respond. The other one did respond, but was also on steroids, so it's unclear whether they responded to the steroids or to anakinra. Endothelial activation and T cell trafficking is also an important avenue to look at. As I mentioned before, there's strong evidence that endothelial activation is a driver of the breakdown of the blood-brain barrier and then development of ICANS. So there's a study that's looking at using defibrotide, which we often use in the transplant world in veno-occlusive disease or sinusoidal obstruction syndrome. It's an endothelial cell protectant, essentially. And so there is one phase 1 study looking at this to prevent ICANS. Also, T cells basically traffic into the CNS, and this is affected by endothelial cell activation, where the T cells, they're rolling and tethering in their movement. So this is an important pathway to look at as well. And we're looking at developing a study of, which many of you may be familiar with from the MS world, the drug natalizumab, which is an integrin inhibitor. We're looking at to use maybe one dose prophylactically with the higher risk CAR T cells like Yescarta, which is known to cause more CNS toxicity, to help prevent some of the T cell trafficking into the CNS that may be responsible for some of these symptoms. So this is just a table that shows some of the ongoing interventional and prophylactic trials that I've mentioned, either inhibition of IL-6 or IL-6 receptor, as we got a question about, using corticosteroids earlier, using anti-GM-CSF antibodies, using IL-1 inhibition with anakinra, using etanercept for TNF-alpha inhibition. Ruxolitinib, which is a JAK inhibitor, is being looked at because it's very good at killing T cells. And so it's also a pathway that's used in the development or used by IL-6 and GM-CSF, so potentially mitigating that pathway. BTK and ITK inhibition with the drug ibrutinib. So there are multiple drugs that are being looked at. Everything is there are some that are still preclinical and others are very early in the phase 1 stage. So in summary, ICANS is now a well-recognized toxicity that's associated with CAR T cell therapy and really with multiple different types of immune effector cells. It's also seen in non-CAR T cell therapy with other types of T cells. We know that patients should be monitored closely during the acute 10 to 14 day period after infusion and should be monitored at least weekly for the next 6 to 8 weeks. Early intervention with steroids and rapid taper could potentially decrease severity, progression, and death. We don't know of what type of long-term residual effects patients may have, but there are multiple studies, and we have one here where we're looking at long-term cognitive effects. And there are multiple prophylactic and interventional trials that are ongoing. So this can be a very severe toxicity. I think overall, the last time I spoke with your group was about 2 years ago. I think we are better at recognizing this now and better at treating it and treating it early. So I think we have seen less neurologic toxicity progression to higher grades. We still are seeing a pretty high incidence, but hopefully we will have some prophylactic and other interventions that we can bring into the clinical world soon. So that's all I have. If you have any questions, you can let me know or send it to me through the chat, and I'll try to answer them the best I can. You're welcome, and thank you for having me here. If anybody has any questions or anything they'd like to discuss, you can always email me. This is my email, and I'd be happy to talk really with anybody who wants to discuss our use of seizure prophylaxis, or if there are any ideas, if anybody's interested in working on some of these clinical trials we have going. This is an area that I'm interested in and hoping to develop a couple of different potentially prophylactic or interventional studies. So let me know if anybody has any questions. Yeah, with natalizumab or Tysabri, we're working with Biogen, who manufactures the drug. They're a little hesitant. I know there is the history with JC virus. I think that that's also something that we're not as concerned about. These patients are going to be monitored very closely. It'll just be one dose. It seems like that risk of JC virus was associated with multiple doses, but I think it does make good sense. We use other integrin inhibiting monoclonal antibodies in the treatment of graft versus host disease. We've used some with very good outcomes in GI graft versus host disease. So I think the mechanism is pretty similar in preventing T cell trafficking. I think it could potentially be beneficial. Oh, and I think Larry, you mentioned treating with steroids interferes with benefit. Yes, so treating with steroids does potentially affect the efficacy of the CAR T cells. However, I think not to the extent that we thought previously. It really seems to be more dose dependent, and it seems to be which patients you're treating and when you're treating them. Just because this is such a dynamic drug, the T cell kinetics, the expansion of the T cells varies day to day, and the various cytokines that are involved. So it's difficult, but we are seeing that using lower doses of steroid for shorter courses with quick tapers does not seem to interfere as much with benefit. Okay. Of course. Thank you all. All right. Thank you for having me. Carol, I'm going to